phenomenal physician, leader in the community of Montana.
Get out of here.
Dr. Tom Roberts.
It's been a pleasure to get to know David. But he does exaggerate sometimes. Can you guys all hear me for this little thing?
No. No.
Okay. You can hear me if I stand up here?
Yes.
Yeah. All right. Well, it looks like I'm going to be standing behind the podium then. And this thing is not working, right? On. Okay. Let me just set it down. Well, as David exaggerated, my name is Tom Roberts. I'm primarily a physician. I work in Missoula, Montana, where I've been practicing internal medicine since 1981, so about 30 years. That's probably my major hat. I also am the president of the Western Montana Clinic, which in Missoula and even in Montana is still a relatively good-sized group, about 40 doctors and 300 employees, and also have some other interests involving healthcare, which go to the City County Health Department. I'm on the board for that, and also work with the Montana Medical Association. And I'm here to talk to you today about an effort that a very talented group of people have been trying to put together for the state, which is a cooperative, a health cooperative, and I'll explain what that's about as we go through this. I realized that we had talented people on the board, and the introduction for David was no surprise. David's on our board and has been a participant and very helpful in moving forward. Bill Kennedy, sitting over here, has been active as well. We've been trying to pull in lots of different folks with lots of talents to make this thing a reality. The reality is, though, that healthcare in Montana and in the nation is under pretty severe stress. And if it wasn't, we would be having me here today to talk to you about new options for how do we solve some of these problems. I thought I'd take the opportunity to describe some of those issues today for you and sort of set the stage for why we are trying to develop something new. So in front of you today you've got, I hope, you picked up both the frequently asked questions about the co-op, what it is, and then as we go through my talk, you've got in front of you, again, hope you picked it up, a copy of my slides. Now I want to start out by saying that each of these slides is fairly dense, and I'm covering a lot of topics here today. I'm not going to go into the slides in a lot of detail, but we could probably spend a whole hour on any one of these slides. These are major topics. They all fit together to form the whole, but each one is a particularly important area. So if I can make this work, we wouldn't be here today if it wasn't for this slide, or I wouldn't be here today. The cost of healthcare in the United States is rising at a very dramatic rate. You can see that the amount of money that we're spending in comparison to other countries around the world is significantly more. It's sort of amazing to start looking at this in some detail, but these numbers are real. We're spending now about $8,000 per person every year on healthcare. It's about $2.5 trillion expenditure in the United States. It's about twice as much as other countries are spending, whether you look at it in terms of absolute dollars or whether it's a function of the gross domestic product. The GDP percentage is increasing, so that now if you spend $1, about 18 cents of that is going to healthcare. Anytime you spend $1 in this country, it's sort of a hidden tax. So the amount of money that we're spending on healthcare is dramatic, but also what's dramatic is just the shape of that curve. What happens if it keeps going up? And that's what's got a lot of people worried. If we've been doing this for 30 years, what happens over the next 30 years? Where do we end up? We're going to end up at 20% of GDP, $10,000, or is that curve, that slope going to keep going? So a lot of times what we talk about is not stopping spending or lowering spending or even not increasing spending. What we talk about is bending the curve. Of course, as the spending has gone up, the amount of money that we spend on health insurance has gone up. You can see that over the last 11 years, the cost of health insurance has gone up 139%, 2.5 times what it was 11 years ago. And right along with that, we've been costing people who are buying health insurance, not just the employers, but the employees as well, so that the workers' contribution to their own health care has gone up again about 2.5 times over the last 11 years. And contrast that with wages, which have stayed pretty close to inflation. The upshot of that is that, and this is a slightly difficult slide, but look on the left-hand side of the slide, and this is monthly income. What's actually happened during the last 10 years, 1999 to 2009, is that wages, income have stayed about the same, so that even though GDP has gone up, production for workers gone up, people are not taking any more money home. So this is dollars per month, average family of 4, taking home an extra $75 to $100 a month. If we had been able to bend the curve, that is, to keep health inflation sort of coincident with GDP and even a little bit more, people would have been taking home another $325 per month for an average family. And if we had been able to keep healthcare spending coincident with inflation, it would have been an extra $500. The blue lines are sort of interesting on this graph because that shows what really is happening overall healthcare-wise. And the blue is what the government has been borrowing in order to pay for the government healthcare programs. So that we take into account how much we're spending not only privately but nationally on healthcare, actually people are losing ground as time goes on. This creates a number of problems. One of the big problems is that people who need healthcare don't get it. And on this slide, we can see that in the last year, in the year 2010, about 1/3 of adults in the United States avoided getting some type of health care because of costs. The things that they looked at with this were, did you skip doctor's appointments? Did you avoid getting medicines? Did you avoid getting follow-up because of costs? And that's a pretty bad statement, especially when you compare it to what's going on in the rest of the world. So, for example, the United Kingdom on the left-hand side there, essentially costs don't prevent people from getting medical care. Not only getting medical care, but certainly we're all familiar with the underinsured and uninsured in the country. I'm not going to spend a lot of time on this slide, but I think you can see the contrast between the left-hand side and the right-hand side in terms of the map. There's more darker colors indicating that more and more people in the United States are no longer getting insurance simply because of cost. Montana, right now, it's about 23% of adults between the ages of 19 and 64 don't have insurance. We do better with kids because of Medicaid and CHIP programs. We're about 10% uninsured. but that number has been increasing, and certainly we're well aware that nationally 50 million people don't have insurance. This is a striking slide in terms of what's happening with medical debt. 40% of people in the United States right now are in debt medically. That is, they have trouble paying for their medical bills. They've had to change their lifestyle because of medical bills. They've got collection agencies or they're paying on an ongoing basis, monthly payments. Of course, if you compare on the right-hand side those with insurance and without insurance, it makes sense that people without insurance are much more likely to have medical bills. And again, poor people, would be a common theme through thinking about health care, are more likely to have medical debt as well. Now, one of the paradoxes in the United States is that we spend a lot of money on medical care. We've got a nice little background noise there too, so twice as much as other places, and yet the quality isn't as good. So I think it would be easy to make an argument that, well, we are willing to pay a lot of money, but what we expect out of that is good quality in medical care and good statistics. But the sad truth is that if you look at statistics on how we're doing throughout the United States, we don't do as well as other countries. This is one example of that, simply mortality. Mortality is the number of children, infants that died, that were born alive and died within 1 year. And if you compare what's going on in the United States with what's happening around the rest of the world, you can see that our infant mortality is 6.8 per 1,000 live births. That means that about 7 infants die every year that are born out of 1,000, as compared with other developed countries who are doing a better job of that. You can look at lots of different kinds of statistics. In general, the United States falls at the back end in many of these. The other interesting thing that this slide shows is that some states do better than other states. And so if you look at the average of 6.8 and then the 10 worst states where the infant mortality is about 9.9, the best where it's 5.0. Just for perspective, Montana is about 5.8. We're 15th in terms of being able to provide good prenatal care and care for the children. As you might expect, if you're poor or if you're black, the rate's much higher, so that in the United States, if you're poor and black, the rate's at 14. So it's about twice what it is for others, and I think that's pretty common throughout the United States to see a differential between the poor and the wealthy. And this is, again, a slightly difficult slide, and we could spend a lot of time on this, but the United States, compared to all the other developed countries that were looked at, does poorly in terms of preventable deaths. So that if you have diabetes, or if you have had a stroke, heart disease, you get a bacterial infection, what are the chances that you're going to come out of that alive? It turns out that it's worse in the United States than it is in other countries. So we spend a lot of money, but for a lot of medical care, we're really not meeting what we should be able to do. In France, it's about half as likely that you're going to die from one of these diseases as it is in the United States. Part of that is because it's hard to get in to see doctors. You think that with the amount of money and the number of doctors that we have, that it should be relatively easy to get in to see doctors, but as it turns out, we don't do a very good job of that. Now, here we're not actually quite last, it's Canada, David, so even though Canada does pretty well, if you need medical attention and you've had some underlying illness and you want to get in, either that day or the next day, only about 40% of those people are able to get in to see their doctors in the United States, which, you know, is stupid, but that's the way we work it. If you live in the Netherlands, 80% of those people can get in the next day. This slide probably doesn't need too much explanation, but if you live in Canada, you go to the emergency room more often than you do in the United States, but that's small consolation because in the United States we don't do quite as well as anybody else, again, in developed countries. And I don't probably have to tell you folks, but you know, a lot of my friends are emergency room doctors, they're great doctors, but they're also very expensive doctors. You go to see a doctor that you don't know, you're out to get a CAT scan and lots of blood tests and see a lot of nurses and come home with a very big bill. But also, for sick people, seeing an emergency room doctor is not really the best thing. I mean, what you really want to do is see your regular doctor who knows you and knows what to look after. But we don't do very well with that here in the United States. Part of the reason is primary care. That's sort of my bread and butter is primary care, and when I approach this whole set of topics, I approach it as a primary care doctor. And anybody that's heard me talk before understands that I really believe that if you don't have an effective primary care system, you cannot have an effective healthcare system. In England, for example, 70% of the doctors are primary care physicians and 30% are specialists. The primary care doctors get paid well, and specialists, especially if they're employed by a hospital, tend to make a little bit less. I see Doug Carr over here, and from the Glen's Clinic. Thanks, Doug, for coming over to listen to this. Doug and I have been involved in a little project. Doug actually has been more involved than I have in Montana in trying to develop a patient-centered medical home, which would in fact reward primary care doctors for hanging in there and providing good coordinated care. So we're happy to see that project going, but you know, from my standpoint, it's a little bit too little and a little bit too late. In the United States right now, if you only about 50% of people, as you can see here, have primary care doctors that they can call out and get into. And of course, if you're black or Hispanic or poor, you're much less likely to have a primary care doctor. Now again, this is one of those slides that I could probably talk about for an hour or two. One of the problems that we have with primary care is that we simply are not producing any primary care doctors. One of my medical students, when I said, you know, you'd be a great general internist, looked at me and asked me if I was crazy. He said, why would I go into general internal medicine? And after discussion with him about that, I had to agree. I mean, it just makes no sense to do primary care these days. So if you're a medical student, about 95 out of 100 medical students are making that same decision. They're not going into primary care. 95% want to do specialty medicine. So the problem that we have now in terms of accessing primary care, I don't see how that's not going to get worse. Medical care tends to be split up in the United States. And what that means is that we have people that are seeing 6 or 8 or 10 doctors, especially folks with a lot of chronic diseases. And those doctors prescribe different medications and order different tests. And what happens is that mistakes are made. And we're not doing a very good job are in mistake-free medical care in the United States right now. I don't know if anybody of you ever have had this experience of getting another test done that was already done, but we're also not doing a real good job of that. So in the United States, people who are sick, close to 1 in 5 have had extra medical tests done. That is something where they go to see one doctor and he just simply doesn't have the results from another physician, and blood gets done again. Going to the emergency room is a good example of that. And this is one of my least favorite slides, but you know, the experience of showing up to see a doctor and the doctor simply not having the medical test results available to talk to you about what's going on. Again, that's something that is not happening well in the United States, and for a variety of reasons seems to be managed pretty well in some other places. Part of the reason, and certainly Dr. Carr and I have been involved in this, this discussion as well, probably up to our ears, is the use of electronic medical records. So that in the United States, you can see that it's changing right now, and increasing numbers of docs, especially primary docs, do have electronic medical records. But it's really impressive to look around the world and see what's going on in other places. A friend of mine who was down in New Zealand recently said, you know, every single person that he saw had an electronic medical record. A day or two after he saw the patient, his note was on the electronic medical record, so that if the patient went in anywhere in New Zealand the following day, they could look and see exactly what he had done. Now, we're doing a better job of creating electronic medical records here in the U.S., but I'll tell you what, we're not doing a very good job of connecting those, so that if you're seeing in billings now for a problem and get onto an electronic medical record in terms of what your visit was about, and then you come to see me in Missoula, I'm not going to have access to your data. Now, again, we're working on that, and it may turn around. We may eventually get to the point where that stuff is available, but at this point, it's simply not. Again, we could talk about that for an hour or two, and I'm not going to belabor that point too much. One of the other really discouraging components of American medicine is how much money we spend on the healthcare administration. And you can see that per year we spend $530 in 2009 simply on our insurance companies. This is not what we spend in my office. This is what insurance companies are spending. And you can compare that and see again that we're about twice as much as any other developed country. I had no idea how Japan does it at $53 a person per year, but that's pretty incredible. I can tell you, for example, that the other component of this is how much the doctors spend in their offices on getting paid. That's not even in this factor, or in this figure. It's about $88,000 per doc per year, just to simply deal with the complexity of the insurance companies. In Canada, David, you guys are ahead, it's about a quarter of that. So only need a quarter of the people to collect the money. But what that creates is a very difficult situation for private physicians, because they're already spending a huge amount of money and time and energy simply in dealing with insurance companies, getting calls from insurance companies, getting the bills in, getting denials dealt with. I mean, it has gotten to be a real mess out there for docs. And in part because of that, physicians have really tried to figure out ways to avoid it. And a lot of the ways that we've done that in my Montana especially, but I think around the rest of the country, is simply to give up and go somewhere else. So one of the common places to go is to be hospital employed, have the hospital do that. In the last, right now, in Montana, 1/2 of all the physicians are employed by hospitals. Can you believe that? 1/2. 5 years ago, I bet it was less than 10%. So that we're seeing a real change in the way that healthcare is organized and even provided in our state because of that kind of development. This has some bearing on the rest of what we'll talk about today, but in many parts of the country, in terms of insurance, there is not a lot of competition. In 37 states, the largest insurer provides over half of all insurance individuals. We don't have that listed for Montana, but I think it's probably true. In 17 states, it's one insurer provides over 2/3 of the insurance in the individual market. And if you look around the country, many markets, again, we could spend a long time on one of these slides or one of these concepts, there are one or two dominant insurance companies. There's really not a lot of competition in terms of insurance products around the country. And I'm not going to spend time giving you the inside story on what happened with Blue Cross and New West, but simply to say that New West is out of the commercial insurance business at this point, and except for the Department of Justice intervention, we probably would have just 2 major insurance carriers here in Montana instead of maybe 3 at this point. This is actually my favorite slide, and I just want to spend a little bit of time on this one. One of the conundrums about medical care in the United States is the variability of medical care and the variability of costs. You would think that things would be pretty even across the spectrum in terms of how care is provided and what it costs, but it turns out that that's just absolutely not true. And this slide is an illustration of that fact. People have devoted their entire careers to trying to understand why is it that in some places in the country, medical care costs half as much as it does in other places. Some places, some areas, its variability can be by 1/3. So some areas spend 1/3 of what other areas do. And this illustrates that in terms of diabetes, heart failure, and chronic obstructive lung disease. You can see that the amount of money that's spent varies from the lowest, $33,000 on an individual per year, to $67,000. And again, if you look at this kind of information and try to tease out the components of it, do the people that are spending more money get better care? Are they more satisfied with the care? Do they have better outcomes? Do they live longer? Do their knees work better? The answer is no. The care outcomes, the satisfaction, everything is pretty much the same in the high cost versus the low cost. In fact, there's a lot of very good evidence that the best quality of medical care is actually the lowest cost of medical care. So that these organizations, these hospitals that are able to provide low-cost medical care, in many cases, are the best in terms of outcomes and the best in terms of quality. So that has to get all of us thinking about how is medical care provided and what are we doing to find the best way to get the best outcomes at the lowest costs. And from looking at these organizations that are doing this, and from actually looking at people within those organizations that are providing low-cost, high-quality care, we absolutely know that it can be done. And that's where you hear numbers in terms of 30% of healthcare costs are probably unnecessary because we look at the high cost versus the low cost organizations. And we can see that, you know, for a lower amount of money, we can be providing good care. And that 1/3 makes a lot of difference if you're spending $2.5 trillion a year. We could figure out ways to be at the 10% level on this graph and provide care at that cost that was high quality. And that slope of that line that we see going up on the first slide would be flat. And that's really what we're after here. It's not to try and figure out ways to lower the costs or get everybody down to the best, but just really how do we slow things down? So the question is, how do we get there? What do we need to do to move from where we are right now to kind of healthcare that we really need? And that is the $800 billion a year question. I mean, what is it that it needs to be done at this point? And I can tell you that a lot of very, very smart people and very good people have been scratching their heads about this one, and there are lots and lots and lots of options for moving ahead. I'm not sure that all those options are available. In fact, I know they're not to us here in Montana. And what works for Montana may be very different than what works for other parts of the country. So what can we do here in Montana? And that leads us into what David actually invited me out here for today, which is to talk about the Montana Healthcare Co-op. And I can tell you that this is a virtual co-op right now. We have been working on this for a couple of years. We've got some very, very exciting and thoughtful people on the board. David included, and I just sort of follow along with their leads. But these people come to the board with the same kind of perspective that I do, not from a primary care standpoint, but you can imagine that David, as an administrator for Rimrock, is looking at healthcare costs and how to provide care differently than I do as a primary care internist. We have county commissioners, we have people that used to direct hospitals, we have private employers, and I'll tell you, they look at it very differently from how I look at it in terms of cost. We have some benefits managers who look at it from an insurance standpoint. But what we all are sort of focused on is, given the issues that I just presented and given our own perspectives, what is possible here in Montana? So the co-op is, interestingly, stands for something. It stands for Consumer-Owned and Operated Plan. Co-op is run by the people who use its services. And as I'll show you, the co-op members sort of direct things by electing the board and serving on the board to decide how things are going to be spent and what kind of services are. In the United States, there's over 29,000 co-ops. Too many people, $652 billion a year. Montana is one of the places where co-ops have thrived. Very common in rural states, so that's sort of exciting when we look at this from a healthcare standpoint. The health co-op idea is that it will be a health insurance plan, and its mission, if we're successful, number one is to improve competition by providing additional plan choices, primarily for individuals and small groups, but also for large groups. And the idea here is, can people who are actually receiving the services of this, that are getting health care, be consumer-driven? Would that make a difference in terms of the kind of choices that you make for how you get health care and where you get it? And our belief is that it will. and that through this kind of organization, we can provide high-quality, low-cost care. We can help to coordinate the kind of care that people want so that those mistakes don't show up. And we really look at this as a way to start transforming the healthcare system. I will say that currently our attempts to transform the system have not been spectacularly effective. There was a recent study in the last week or two that a lot of us saw, which looked at all the projects that Medicare has done, which has done a lot trying to figure out how to provide better quality and low-cost care. And the bottom line was none of the projects worked. They're not saving money and improving quality. Now, within that, there's certain examples of things that do work. But our sense is that we really need to have some kind of innovative change in the way that healthcare insurance is provided and healthcare itself is provided, and we need an innovator, something that's going to make a difference here. The way that we hope to be able to do this is by looking at some of the areas that I just covered. And I don't think we can have a system without primary care. People have begun to look at variability, especially in terms of which hospitals are providing better services and better outcomes. Even within Montana, there's significant variation. We don't hear about that, but there is, and there's better cost values and better quality values. Wellness tends not to be emphasized, but I can tell you that we've got a huge problem about to crash on us in terms of diabetes in this country. And unless we start trying to really deal with diabetes at a very early stage, it's simply going to overwhelm our healthcare system. People who are sick tend not to be receiving coordinated care. One of the things that happens in essentially all groups that are receiving care is that 5% of the people that are getting insurance are spending 50% of their money. 10% are spending about 65 to 70% of the dollars. You can't get a handle on healthcare costs unless you can figure out who that 5% is, how they're spending their money, and intervene to get them cost-effective care. It just can't be done. And so the programs that are instituted to try and take care of everybody in a healthcare program are fine, but in a lot of cases they miss the point, because it's not the 95% that are spending the money, it's the 5% that are spending the money. And what we really need to do, we need to develop effective management tools to identify those people and to help them out. And the other thing we need to do is prevent the 5% from growing the next year, because that 5% changes from one year to the next. But it's possible to figure out who's going to be spending the money next year and to actually intervene early on, and we expect to be able to do that. Pharmacy benefits is a really, really interesting subject, and I can't resist saying a couple words about it. The pharmacy benefits management companies, the ones that are supposed to be giving us deals on getting medicines at cheap rates, are not in it for that. They're in it to make a profit, and they're doing a very good job of that. And it is possible to get around that and get medicines to people at a much cheaper rate than they're letting us do at this point. And we've got a real good example of that ability right now in the state, and university employees who are on a URX plan, which has saved millions, tens of millions of dollars on an ongoing basis by circumventing these pharmacy benefits management. But at the same time, they're providing people with the medicines that they need at the low cost, and the people are taking them. So not only are pharmacy costs reduced in that program, but disease is reduced, because people are not having heart attacks and strokes because they're actually taking their blood pressure medicine and taking their cholesterol-lowering medicine. And then the other thing, of course, no knives intended, but having having an efficient administration of health insurance products is absolutely essential, and we think that's not being done so well. The federal legislation for the co-ops was part of the Affordable Care Act, is part of the Affordable Care Act program. And Ken Conrad, Senator out of North Dakota, I believe, was the one who suggested this. Just looked around and said, look, co-ops are working well for us in other areas. Why don't we get them going here? Initially, the program was funded with $6.6 billion. The idea was to establish a co-op in every state. As that has wound its way through the legislative process, it was reduced to $3.8 billion and now $3.4 billion. So it may or may not turn out to be a high-functioning program through the Affordable Care Act. We'll see. The way that this act is proposing to get these co-ops started is by giving both initial startup loans and then solvency loans. So the startup loans, getting a health insurance company started is not really very expensive. I think it's complicated, but it's not that expensive. But what really is expensive is that the state requires this big, huge chunk of cash to be sitting in the bank to prevent problems should the insurance claim go under. So you have to meet certain requirements to make that go. So co-op programs need to be nonprofit. They need to become health co-ops. The bottom two issues are interesting. When this program was started, they said, we don't want to have anybody in here who is already an insurance plan. We don't want to have the state start these programs. So you can't have, Blue Cross can't start one, for example, US can't start one. Co-op is based on consumer governance, so that every member of the board is to be elected by a majority vote of co-op members. And the board itself, the board that directs the program, has to have a majority of co-op members on it. Again, no government people and no insurers on that. The idea with profits here, this is a non-profit company. Any profits need to be put back into the company in terms of lower premiums or better benefits, to improve the quality of health care for the members. These are all loans, it's not a grant, so if we're successful in getting a loan, it has to be paid back, and we need to keep some reserves. So I just want to run through a brief timeline. I think we can open it up for questions in a couple of minutes here, but we started working on this just about 2 years ago. We formed a mutual benefit company. We decided to move ahead. In July of this year, funding announcement came out from the feds, and we hired a project officer, got private donations, hawked my retirement, and we got this going. We had to get an application in by October 17th. It was a lot of hard work to make that happen, but we did. We were about the 4th in the country to get ours in. I think we're sitting right up there. And we met with folks back in Washington to discuss it. Actually, I keep checking my email and my phone today because we think that this week we're going to get an announcement about whether or not we receive the funding for this. And if so, we'll start implementing the process, and by the summer of 2013, next year, I hope to have a product that's available for Montanans. And as I said, members will elect the board about a year later, and the full board a year after that. So I think that's enough. That's a very quick overview of healthcare in the United States. There's a couple of little slides, but I don't think they're that important. And some explanation of what we think we can accomplish here. So I'm supposed to open it up for questions. Happy to take any questions as long as they're not too hard. If they're too hard, I'll just think of a convenient different answer. We'll start with you, sir.
In your statistics, in the first part of your presentation, you talked about the United States. Have you broken it out, got for the state of Montana as an example, and how it compares with these other areas?
Not for most of those things. I said for infant mortality, we're number 15 in the country, 15 best in the country. In terms of insurance, we're near the very bottom of the pile in terms of the number of people that have insurance. I don't really have statistics for Montana that look at things like how long does it take to get in to see the doctor. I think that in general, we don't have a very good primary care system here in Montana. You guys do have a good one down here, and you've got the family practice residency program. We're trying to develop one of those in Missoula. I think that would be helpful. But it would be interesting to look at some of those things, wouldn't it? In general, Montana, if you just look at Medicare data, tends to do a little bit better in terms of low cost and high quality than some of the other places in the country. It's not to say that we are uniformly that good, but compared to some of the southeast and southern states, for example, where they tend to spend a lot of money and have poor quality, we do pretty good. But I think overall we're doing okay. It's sort of a weak positive, but we're not doing bad in comparison. Yeah.
If there's a change in the administration this fall, and there's a flip in the Senate with regards to the seating, and Obamacare or the Affordable Care Act is defunded, will the cooperative continue?
Yeah, that's a good question, and I sort of expected it. I should have said something. The other component of that, of course, is what happens with the Supreme Court in March. Will the individual mandate be declared unconstitutional? I think the answer to that is that once a group like ours is awarded the funding, it's got the funding, so that if we get the necessary award this week or next month or the month after that, the money's in the bank, so to speak, so we'll move ahead. Certainly if the exchange is not ever created and we don't have universal coverage, there's going to be less people that will be involved in being part of the co-op. But we think it's a go no matter what. The Affordable Care Act, it's a big act. I mean, it's 2,000 pages, and it's got lots and lots and lots of different parts to it. So the co-op is 3 or 4 or 5 pages out of that whole big program. So there's a lot of different pieces that will move ahead no matter what happens at the Supreme Court, no matter what happens with the administration and the Senate. So we expect that this will be a reality. Now, part of the strength of the co-op movement in healthcare, I think, would be if every state had a co-op, so that you could then do things like, if you're in Montana and you're in a co-op and you happen to be in New Jersey and you need some healthcare, you could get it the same way you do with Blues right now. That is compromised at this point by the funding, so that the less broad this is, the less of an option it is for people and for the country. Yeah.
Do you envision mental health being on?
Oh yeah, of course. Yeah. I mean, I couldn't say anything different at this group. Right? Yeah, mental health will be a part of the co-op. It has to be. You've got it. Yeah. Yeah, back down. Yeah.
I applaud what you're doing, and I want to believe that health should be more like a utility and less like insurance. because we pay more for what we use.
We tend to use healthcare less in the United States than other countries, so that there's less hospital beds, there's less doctors, there's less doctor visits in the United States compared to these other developed countries.
So we're paying more for what we use.
We pay more for what we use.
And then, are you going to be tied or will co-op be tied to a specific set of doctors or hospital, or how is that going to be?
So the question is, will the co-op be tied to a specific set of doctors or hospitals? The answer is yes and no. I don't think it's going to be that easy. What we would hope to develop and hope to encourage would be good primary care around the state, and that might be with existing primary care groups, existing hospital groups, but it could also be with new primary care clinics that would get set up. And what we'll be looking at, I hope and expect, is trying to figure out which hospitals and which specialists in the state are providing the most cost-efficient care. So if we look at what it costs to get a heart bypass, for example, in the state, there's tremendous variation in the order of $40,000 to $60,000 per hospitalization for heart bypass. And the ones that are more expensive tend to be the ones that stay in the hospital a little bit longer and have more complications. So again, that's not something that any of the hospitals are advertising or is very obvious, but our hope is that we can identify best practices and best places to have those high-cost things done and direct people to those. Not to say that you couldn't get something done at any hospital you want, but you might pay a little bit more to have that done. So our expectation is that we would help to direct people to the higher cost, higher quality, lower cost. Yeah, get that right. Yep.
Will this do anything to improve the quality and accessibility of people in rural Montana to health care, or will this be just one more item that goes into the 5 or 6 medical hubs in the state to help grow them?
And so the question is, will we be able to support rural health care as well as health care in the centers? One of the requirements, actually, of this, which I didn't emphasize, is that it needs to be rurally, and there needs to be an emphasis on rural health care. So we're very early in this, but our expectation and hope is that we can figure out ways to improve the quality of medical care and the accessibility in those rural areas. And we have some ideas. I mean, one of them would be, can you get primary care docs to start rotating through those areas? Right now, physicians are paid based on actually seeing patients in the office. I mean, we're not paid to do phone calls, we're not paid to do telemedicine, we're not paid to do emails, that kind of thing, which is stupid. If you're managing with people, you should be able to talk to them in any different way that you can in order to get them the kind of care they need when they need it, as opposed to making them come to the office in order for you to get paid. So I think telemedicine and emails and that kind of thing could be a useful approach to dealing with rural Montana, which, as you know, is under assault because it's hard to get primary care docs and good doctors that go into those areas. Kim?
My question is about the Supreme Court case.
Yeah.
Suppose the Supreme Court rules that individual mandate is illegal, but that it's severable from the rest of the law, and you wind up with the Affordable Care Act with no requirement that people buy insurance, but you still have to cover everybody regardless of pre-existing conditions and so forth. Is your co-op business plan still viable without the individual mandate? Does it make it much tougher to be sustainable?
So the question relates to what happens if people, I think your question is this, if people can continue to buy insurance whenever they want to, that is that the, I'm just blocking what that's called, but part of the Affordable Care Act is that you have to get medical insurance, but that the insurance companies have to provide that to you at community rating. And so if people don't have to buy insurance, but they can still get it if they want to, or when they want to, guaranteed issue is the name I was trying to come up with, then that affects not only co-op, but it affects every single insurance company in the United States. And so that kind of decision that would cut out the individual mandate without also putting restrictions on guaranteed issue and community rating, the cost component, simply won't work. And so we'd have to have something that would step in. And I don't know what that would be. I think it would be a problem for Montana Health Co-op, but it would also be a problem for Blue Cross. It would also be a problem for any other commercial insurance. And so we need to come up with a solution for that. Just 1 second, I'll get to you. There's a couple other components, of course, to the Supreme Court case that are coming up, and it's very, very interesting to see how all of those issues are going to be handled. One of the big ones is the Medicaid expansion. And so a lot of states have sued to suggest that the federal government should not have the ability to tell every state that they need to expand their Medicare rolls. In Montana, with the expansion of 70,000 to 80,000 people. And so that's coming up as well. So what's going to happen with Medicaid and are the people that are poor now and unable to afford insurance, who really couldn't buy insurance and won't buy co-op insurance or Blue Cross insurance, but could be insured through Medicaid, is the Affordable Care Act can legally create that kind of mandate for Medicaid. So, and then the other component of the Supreme Court case is, can they even decide? I mean, they're going to face that issue as well. There's something about taxes is the tax or the penalty on not joining a tax. And if it is, there's some rule that, I think it's called the anti-injunction rule, that says you can't sue to stop something unless it is actually happening. So that's another component of the Supreme Court is going to be facing. So it'll be fascinating. I mean, part of the thrill of being involved in this is things are changing so dramatically, and they're so interesting right now that just to be part of it and see what's going on. I mean, I can't stand up here and tell you that co-op is going to change everything about healthcare in the United States. I wish I could have that conviction. I think it's an interesting concept. I think we should try it out and see. It looks like it's a good issue, a good thing to try, but lots of people have lots of good ideas and they don't work. So is this going to work? I think so, but you've got to put it into play and see what happens. You had your hand on that.
Yeah, my question was in the Healthcare Reform Act, medical liability and tort reform was left out, and that obviously affects physicians and the cost of their practices and along with their education.
Some of those are malpractice lawyers, and some of the cases that I have seen have just been horrendous from the standpoint of expense and outcome for the patient, outcome for the doctor. And so I really strongly support anything that we can do to make sense out of the whole tort system. People that are only about 1 out of 7 people that are actually injured by medical care receive any kind of compensation for it. And many of the cases that are brought are just total hogwash. I mean, they just don't relate to the real problems. So I'm strongly in favor of that. The question of whether or not tort reform would actually change the way that physicians practice practice and lower expenses, I think there probably would, but I don't think it would be enough to make a huge amount of difference. And so I'm supportive of it. I think we have a lousy system. I would love to see major changes. There's certainly bills that are in the legislative session that the Montana Medical Association has been strongly pushing, which I support. They were passed by the both houses last time around. The governor vetoed them or didn't sign them, so they didn't go into law. So they'll be back up again this legislative session. We'll be trying to get them passed. Again, I don't know how far they'll go. I don't know if it'll make a difference if they do happen. So, you know, that's again a long discussion. Hope I didn't offend any orders. Maybe I did. Yeah.
No,
yeah, no, okay.
I'm one of these guys that want.
Okay, but
Is the co-op designed to compete with Blue Cross and the private insurance industry? And if so, what is their position with respect to this entire project?
what would you imagine their position might be?
I'd just like to hear it from the source.
You know, I am I'm friends with the guys at Blue Cross. I was on a phone call yesterday with them in the afternoon about the medical home project. We work together all the time. I think they're good people. I think they try to do what's good for the state and also what's good for Blue Cross. And having more competition is not good for profitability of a company. It just isn't. So they have not overtly tried to stop the co-op. I'll leave it at that.
When it comes to primary care physicians and the community's knowledge about where they are, what services they perform, what their hours are, when I can reach them, how much of that is a community outreach problem? And in fact, I look at what we do for hospitals with signage exemptions, and we put up street signs directing people to a place where they can get medical attention, because it's a large entity that brings in a lot of business for that community. And I can see that involvement. Is that a problem with the small private practice? Do they not? Is there sign restrictions, stuff like that, that doesn't allow them to let the? Is that an issue for primary care?
Well, let me totally put myself out on the line here before David puts the hook around my neck and pulls me off. Seeing primary care physicians is not profitable for hospitals. Okay? It just isn't. And not to badmouth hospitals. I've worked in hospitals since I was 16. I mean, I love them and they have their place, but if you're a hospital administrator and you're looking at the bottom line is not going to be improved by hiring more primary care doctors and getting people in to see them. Just flat out isn't. It's going to be improved by hiring more orthopedic surgeons, more neurosurgeons, more pain physicians, more cardiologists. In Missoula, we have more cardiologists per population than any other place in the country. We have more cardiac catheterizations than just about any place in the country. Now, I could point a finger at Billings and tell you that you have more back surgeons here than we do. And guess who has more back surgeries than we do? The hospitals, I mean, it's just the economics. It doesn't make any sense. And if you want to save money and provide good health care, you create doctors like I used to do, who take care of old people on an ongoing basis, and keep them out of the hands of specialists, and keep them out of the hospital, and keep them out of the emergency room, and make sure they're taking their medicines, make sure they get the right tests, and make sure they get in to see me on a regular basis. That doesn't pay. It just flat out doesn't pay. And that's, you know, I'm not doing that anymore. I just couldn't make a living. So we don't have a system that is sensible. We don't have a system that encourages that kind of medical care. We encourage exactly the opposite. So it's not a problem with advertising primary care. It's just a question of, how do we want to create a system that works? And the system works very well right now for what it does, which is to, look at the first slide and you can tell what it does. It doesn't do so well for some of the other parts. So I think that's probably enough. I mean, is that good, David?
Thank you. Thank you for coming, and if you have further questions of Dr. Roberts, he's available and will be answering questions if you wish.